We're going to have a look at a lovely 80-year-old patient here who's got known severe aortic stenosis, and she unfortunately developed bacteremia with Proteus mirabilis, and she's ended up with us. She's not intubated, but she's in shock with lactates that were elevated, moderate amounts of noradrenaline to try and maintain a MAP of 65. And so what we're going to look at now is how to try and have an idea about what fluid balance is going to be. Because obviously you want to make sure that they're not underfilled and hypovolemic, but more importantly I think you also want to make sure that they're not overfilled, and therefore we're risking raised left ventricular diastolic pressures, raised left atrial pressures and pulmonary edema. So I think it's a delicate balance, and Echo's going to help us try and have a look at that. And Emma's going to help me do it. Thank you very much for joining me, Emma. And we'll go from there.
Well, heavily calcified aortic valve with, looks like, significantly restricted opening. We certainly want to interrogate that some more.
Yeah. LV size and
the
function?
LV size looks normal, if not slightly on the small size instead of the cavity size, and she looks like she's got some left ventricular hypertrophy. And just looking at the the relaxation of the infralateral wall, particularly the annulus there, it looks not quite normal, so I'm already suspicious that there may potentially be some diastolic dysfunction.
Yeah, interesting. It's pretty subjective, that though, right?
It is subjective, but I think still useful.
100%, I agree.
To look at.
Some things I might look forward to is increase my depth and just see if I've got any B lines that are coming off at the back. So I'm going to go short axis view. The size, again, backs up what we were thinking before. Left ventricle size, I've got my anterolateral and posteromedial papillary muscles. LV function remains preserved. That's on moderate amounts of catecholamines. Okay, I'm going to come down to an apical view now.
I don't want to touch the buttons. I know how strongly you feel about that.
So apical 4-chamber view. Let's just have a look at the aortic valve first of all, if you're up for that.
Sure.
Okay, so as I come to my 5-chamber view, I bring the aortic valve over to the left side of the screen. I'm going to angle up a tiny bit. As I bring in my 5-chamber view, I can then try and have a look with my continuous wave Doppler and see how I find. I'm going to turn up the sound for this one. And as I'm trying to assess this, first of all, I'll try and get my scales correct. I'll get 3 cardiac cycles. They're in a sinus rhythm in the middle of the screen, and then I'm going to listen. And as I listen, I'm going to look for the most crisp sound as I gently move the probe.
I think there's quite a lot of information that we can get. Firstly, it looks fairly parabolic and, sort of late peaking, which suggests to me more of a severe aortic stenosis. And probably you're going to get max velocities of about 3.5, close to 4. You've been a bit generous with that one, but 3.8. So that, and mean gradients of 38, Vmax of 3.8. So that puts us into moderate category. But we can do a little eyeball where we see what the LVOT velocity is going to be.
Yeah, and it's less than 1, right?
And it looks like that DSI therefore is probably going to be, maybe in the severe
category. Yeah, the dimensionless severity index, just comparing, so the inflow, the inflow of the LVOT in here versus the aortic valve there, and you expect that if it's a quarter or less than the area there being a quarter less than the area there, then you're dealing in that severe category, right?
So you would definitely worry about that, even though your velocities and gradients are not there. And you worry about whether she has a low flow state.
One of the things I'm going to do now is I'm going to try and have a look at the VTI of the LVOT. And one of the things I'm going to look for is that there's this convergent zone almost. So as you go through the aortic stenosis, you can get a build-up of pressure behind it. That can leave you a convergent zone. And so often I'm not looking for that closing click when I'm doing the aortic stenosis severity, because I just want to be out of that convergent zone.
Be in the blue.
Be in the blue. So I was not game to do the LVOT diameter when I was in that parasternal long, because I think I wasn't getting good enough pictures. Here I'm going to take, normally I take sort of 2 or 3 and sort of average them out. Try and avoid the fluff, avoid the beard if you like, no offence Faraz. And here we've got an LVOT VTI of 16.8 versus 104, so definitely in the severe category of that,
severe category, which is interesting. With because just when you put the colour on there, Sam, did you see the MR that was coming through?
Yeah,
so
absolutely.
This is one of the causes potentially of a
low
flow, low gradient.
So low flow, low gradient, despite there being
normal ejection fraction. So this would be.
Because we've got normal ejection fraction, we've got quite significant mitral stenosis, mitral regurg that's coming in there, right?
Yeah, it looks at least moderate based on that.
Try and have a look at some diastolic function. So We've taken some values previously yesterday when she first came in, when she was just being started on the catecholamines, and that had showed maybe some moderate diastolic dysfunction, and I'll try and show those pictures.
Is there anything that's changed in between, like in terms of...
That's fascinating. Okay, so what's changed is the E to A ratio was approximately 1 yesterday, and I think that is markedly changed today with her being about 750 mils positive.
Interesting.
So only 750 mils positive. Emma, what do you think of this?
It looks like a restrictive filling pattern to me, so it looks like, you know, grade 3 diastolic dysfunction. You've got a rip-roaring E velocity.
I think the D cell time is maybe getting a little bit more severe as well. So all E prime averages there, greater, way above 15. So that's suggesting we've got raised left atrial pressure even in the settings of MR.
Yeah.
All right, so I think what we've got evidence of is with 500 or 750 mils extra fluid from starting on the noradrenaline yesterday, we've got worsening looking signs of left atrial pressure estimation. It's maybe suggesting that I think with B lines in there that we're maybe on this edge of her being as well filled as we can. We've got evidence of rising left atrial pressures, so maybe we try and withhold the fluid from here and we'll go from there. We'll try and optimise the fluid as much as we can and just avoid any excess fluid from here. Sound about right?
Yeah, definitely.
All right.
Yeah.
Thank you very, very much for your time. Thank you so much. I really appreciate your time.